Welcome, everyone. For today's HPL seminar, we'll be hearing from Dr. Kevin Dibbern. Dr. Dibbern is currently the co-director of the Orthopedic Functional Imaging Research Lab at the University of Iowa. Dr. Dibbern completed his bachelor's, master's, and PhD at the University of Iowa in biomedical engineering. His PhD was advised by Don Anderson, and he explored objective measures of post-traumatic OA risk. Following his PhD, he also completed a postdoc at the University of Iowa, where he researched using clinically available imaging to predict arthritic progression. His current research interests include understanding the impact of weight bearing on deformity and how to improve diagnostic accuracy. His proudest accomplishments are when data led him in a different direction than what he set out to explore. As an example, he unexpectedly found syndesmotic narrowing when he expected widening as foot deformity progresses. This is leading him to explore nonlinear mechanisms at play during foot collapse progression. Some fun facts about Kevin. He has been to Calgary twice. Once was for the ISB conference. He is a sprinter turned distance runner, which he describes as a work in progress since 2013. He also loves board games, disc and regular golf, and playing the violin. But most of his hobbies now center around playing with Henry, his 3-month-old sidekick. So with that, I'll turn it over to Kevin for his presentation, and then we'll have a question and answer period to follow. So Kevin, you're welcome to start screen sharing whenever you're ready.
Thanks, Emily, and thanks for the introduction. All right, everybody see that? Perfect. All right, well, thank you. I'll be presenting some of our work looking at how weight bearing is impacting foot changes and how we can do 3D assessments of the weight-bearing CT data looking at these changes. So as Emily mentioned, I did my master's, PhD, and a postdoc under Don Anderson here at Iowa, just under a day's drive from Calgary, and was hired on to support weight-bearing CT research here at Iowa, and was able to start the Orthopedic Functional Imaging Research Laboratory in 2020 with Dr. DeCesar Neto, who's our clinical lead here. And so I just thought I'd show a little picture of our lab here, the Orthopedic Functional Imaging Research Lab. And this is, that window right there is where I am. So I'll wave out the window here. And so this was the best I could get for Calgary, for what you guys have for your lab up there. But when I was up there, I was looking through my phone to see what pictures I had of the lab. I visited Brent Edwards up there back in 2018 now. And the parking was the only picture I came away with. So I was a little distracted by some other things that I was taking pictures of. So at the Orthopedic Functional Imaging Research Lab, our goal is to improve patient care through improved understanding of impact weight bearing has on the evaluation of deformities and pathologies. So a lot of what you're going to see in this presentation is going to focus on weight bearing imaging, progressive collapsing foot deformity or flat foot, where a recent consensus on the use of weight bearing CT has highlighted the need for better understanding of its complex 3D effects on the ankle, midfoot, and hindfoot. So while many flat feet progress to pain, it's also equally possible, or maybe even more possible, that they aren't going to progress to pain. But so that makes it very important for us to be able to differentiate which will and why. This is particularly important for joint preserving surgery to know which patients you can operate on and at which point. So in these surgeries, we also need to understand what's happening in 3D to cause both the progression and the pain, so that way it can be corrected, and so that way you're not operating on guys like this who are doing just fine. So finally, The key to all these corrections is to ensure that the ankle remains healthy so patients can continue to function normally. So how do we decide which feet are going to get these interventions? Ideally, research in this area is going to identify markers of progression to determine not only which feet to operate on, but when. So recently, weight-bearing CT has been increasingly utilized to the point of a consensus on its utility in evaluating progressive collapsing foot deformity. However, despite these advances, there's still no gold standard for evaluation, so we rely on surgeon experience and interpretation of the best markers available. This has highlighted the need for more accurate and complete 3D understanding of the deformity to aid in these decisions. For this talk, I'll give a brief overview of our work examining hindfoot subluxation, midfoot subluxation through the Chopart joint, and tibio-talar involvement in flexible PCFD, as well as its surgical correction. And I'm not sure I'm going to have time to get to the syndesmosis today. So we'll see where we end up. So starting with the hindfoot, we know that this is a complex deformity involving a lot of moving components, but a primary one is peritailor subluxation, and it's typically measured through the hindfoot here. A recent paper has established that the middle facet is perhaps a better place to be looking at this deformity progression than the posterior facet, which had been the clinical standard. So our study sought to evaluate the 3D distances and coverage maps across this entire peritalar surface to identify where the subluxation is occurring and if there's any impingement occurring in these cases. So to do this, we looked at 30 patients with 20 consecutive flat feet that were stage 1 flexible. And we used coverage maps and distance maps created of the talus, calcaneus, and fibula to look at these regions. We divided the posterior facet into a 3x3 grid and the sinus tarsi into a 2x2 grid, respectively, using PCA. So we segmented the bone, as I'm sure you guys are familiar with. And in order to do our distance maps within the joints, we looked at the normal vectors. But if you notice outside of the joints, the normal vectors might not make so much sense to look at the distances between bones. So within the joints, we kept the normal vectors, and then outside of the joints, we just looked at the straight normal distances. It's the straight vertical distances, excuse me. So we created these coverage maps to highlight regions of interest, with impingement identifying distances less than 0.5 millimeter, uncovered joints being shown in pink. That can sort of be thought of as subluxation, and normal coverage being shown in blue, while covered extra-articular regions with distances greater than 4 millimeters are shown in gray. So this just gives an example of the coverage maps between a control and a PCFD patient. You'll notice that in PCFD, there's a lot of pink showing up here in the middle facet. And here, I get my little pointer going. Yeah, so in the middle facet here, you're seeing a lot of uncoverage and a lot of impingement that's happening here in the sinus tarsi region on the calcaneus, with uncoverage of the posterior facet as well. Looking at this across the board, you see a bunch of blue and not very much red here on these control cases, with a lot more red here in the sinus tarsi regions and a lot more pink showing on all of these facets. So to sort of summarize these results, we saw in bolded white changes that were significant in the sinus tarsi distances, with a significant decrease in the minimum and mean distances in these regions, and a significant increase in the distance in the anterior facet there. And then I'll draw your attention more importantly to this coverage area, looking at the significant increase in coverage of the sinus tarsi in these flat foot patients compared to the controls, and a significant difference in the coverage, losing almost half its coverage of the middle facet when compared to the posterior facet. We also looked at subfibular impingement and saw subfibular impingement in 3 of our 20 cases that we studied, with narrowing greater than 2 standard deviations from controls seen in 17 of the 20 patients we looked at. So summarizing this, these identified significant peritalar subluxation in the middle, but not in the anterior or posterior facets. And this supports the prior data that the middle facet uncoverage might be providing us with a robust marker of peritalar subluxation. A thought here is that the pain might be coming from the sinus tarsi and subfibular impingement. So next, using the techniques that we developed in the first study, we wanted to investigate what changes were evident in the Chopart joint. This is a whole foot problem. So in the Chopart joint, well, most of the prior literature has focused on two-dimensional analyses. Louis and Bill Ledoux identified some changes in coverage of the talonavicular joint associated with Pcfd. They found no true subluxation in the talonavicular joint, but a substantial lateralization of coverage under partial weight-bearing conditions. So we sought to build upon this work by evaluating whether more substantial subluxation occurs during full weight-bearing or in double leg stance using distance and coverage maps that we created to evaluate that hindfoot subluxation. Additionally, we wanted to evaluate subluxation across the entire Chopart joint, shown here between the red talus and calcaneus and the blue navicular and cuboid to determine what changes might need to be corrected in this region. So more specifically, our objective was to characterize the regional subluxation and coverage changes across the entire Chopart joint and identify the relative magnitude of these changes when compared to controls. To test our hypotheses, we evaluated 20 patients with Pcfd and 20 matched controls, selected for having weight-bearing CT imaging available with no prior surgeries or deformities and similar age and BMI. Geometries were extracted from weight-bearing CT data using D0 Bone Logic 2.0 and automated segmentation service, and candidate contact areas for the joints shown in pink were then selected by identifying the subchondral interfaces based on their curvature. Finally, distance and coverage maps were created in MATLAB by projecting the normals as we did before. So to evaluate where the changes were occurring, we used a similar division to the work by Alessio Soren and the International Weight-Bearing CT Society to divide the calcaneo-cuboid into 4 segments and the talar head into 6 segments, and computed the coverage percentage as we've done before. So here we can see a representative control case on the left and a severe Pcfd case on the right. In general, you'll notice overall coverage in the control is higher, and there's a more even distribution of that coverage across the joint surface. Looking at the Pcfd case, the coverage is clearly just decreased in the medial regions on the right side of the talonavicular joint for patients with Pcfd, and perhaps slightly increased on the lateral aspect of the joint. In the calcaneo-cuboid joint, you'll notice a clear superior lateral shift of the coverage and uncoverage inferior medially. Looking at these trends across the cases we studied, you see the sort of wide variability in coverage changes that exist in Pcfd and control patients, with some joints experiencing negligible changes and others complete superior lateral shifts of coverage. Quantifying these changes, significant medial uncoverage was found both inferiorly and superiorly, with coverage reductions over 50% on average on the talar head. And in contrast, lateral coverage increases were a little bit more modest. A similar change occurred in the calcaneo-cuboid joint, with significant decreases in coverage inferiorly and increases superiorly and laterally. You'll also appreciate that the magnitude of coverage changes is similar in both the dorsal and plantar regions, indicating that the subluxation is occurring more medial-laterally rather than plantar dorsally. Globally, considering subluxation as a significant change in joint coverage, we didn't see subluxation as there weren't any significant changes in overall coverage of the talonavicular calcaneo-cuboid joints, indicating that on average, they're not subluxating out of their normal range of motion for double leg stance. Then looking at the distance maps, you see the broad similarities between the control and Pcfd groups. And this is in contrast to the findings previously reported, with significant differences found by the International Weight Bearing CT Society. So directly comparing our results to those of the distance maps reported previously, we see mild widening and narrowing in similar regions of the talonavicular joint, with no significant widening seen anywhere. And the calcaneocuboid joint, we see similar non-significant narrowing, both superiorly and inferiorly. So in summary, the coverage and distance maps were able to identify significant changes through the entire part joint in patients with PCFD for the first time. And while these changes are consistent with midfoot abduction and uncoverage, they are occurring more mediolaterally and not dorsoplantarly, as has been previously reported. So similarly, the calcaneocuboid joint experienced medial uncoverage with significant decreases plantarly and increases superiorlaterally. And the causes for this aren't quite yet clear, but might present subsequent to sinus tarsi impingement or subfibular impingement, as identified in our previous study. So taking our results in the context of the prior work, similar to what Louis and Bill had previously reported, there were significant decreases in medial head coverage. And importantly, even in full weight-bearing scans, these differences in coverage weren't outside of the movement capabilities of the joint, leading us to believe that true subluxation isn't occurring necessarily in these early PCFD patients. So the lack of significant change in distances from the PCFD cohort to our controls is also interesting, as it also sort of indicates that we might be looking then at an earlier subset of deformity compared to theirs. So in conclusion, this was the first study to look at the distance and coverage mapping, characterizing these changes across the entire part joint under full weight bearing conditions. And the talonavicular changes were primarily directed in that sort of unexpected medial-lateral, not dorsal plantar direction. And our hope is to, continue to combine these with the hindfoot data and everything to help us titrate our treatment effects with a goal of optimizing our corrections. So investigating now the tibiotalar involvement in PCFD, we are curious what changes we're going to be seeing in the ankle ahead of the arthritic changes that are seen with late stage PCFD. So clinically, these changes are associated with radiographic measures like the first metatarsal angle here and measures of talar tilt on single radiographic images. So it's critical that we better understand the 3D nature of this change and progression. So Ock and colleagues leveraged weight-bearing CT to call attention to the syndesmotic widening and possible syndesmotic instability in PCFD patients, secondary to chronic and progressive peritailor subluxation, and they speculated these changes might derive from increased stresses in the lateral aspect of the ankle or hindfoot, especially in more chronic and severe deformities. So recently, we were looking at the PCFD distance and coverage maps, and so we wanted to look at these in the ankle as well. So in this study, we sought to expand upon the tools to evaluate the tibiotalar involvement and hypothesized that we'd see similar results to the Ock study with increased syndesmotic distances and volumes as reported, and decreased coverage on the anterior and medial talar surfaces as it plantar flexes and rotates from the lateral stresses associated with the deformity. So for the study, we evaluated 37 patients, 17 with PCFD and 20 controls, and used distance and coverage maps to evaluate both tibiotalar and tibiofibular interactions. We investigated the syndesmotic changes at 1, 3, 5, and 10 centimeters, and the medial and lateral gutter changes. So we divided the talar surface using PCA again to look at a 3x3 grid and the gutters anterior-posteriorly. Similarly, we divided the syndesmosis anterior-posteriorly at the 1, 3, 5, and 10 divisions. So to obtain our syndesmotic distance and volume measurements, we first took normal projections from the tibia and the fibula and averaged those that hit the opposing surface to obtain distance maps, and then used the volume measurements as the area wrapped using an alpha shape with a radius matched to our voxel size to create a concave watertight surface with which we can measure volume. So starting by looking at a representative control in Pcfd map, you'll notice right away that there's anterior narrowing on the tibiofibular interface of the ankle, contrary to the previous findings by Ock et al. And on the right, you see comparable distances on the maps of the control in Pcfd and a large posterior shift in coverage. Looking at a regional comparison of the distance maps in all the cases, you'll notice that only the anterior and lateral gutter showed an increase in mean and minimum distances, indicating that no joint narrowing had occurred, as seen in patients with later stage arthritis. Looking at the syndesmosis, we see global narrowing. It's most significant at 1, 5, and 10 centimeters, with the most significant narrowing happening in that first centimeter. And the tibiotalar coverage, we see that it was significant anterior uncoverage and posterior coverage, and similarly seen in the gutters. Finally, looking at the volumes across the cases, only the medial gutter showed a significant change, reducing in volume by about 30%. So this might be consistent with plantar flexion and a posterior shift of the tibia and medial malleolus, reducing the mated surfaces with which we are using to create the alpha-shaped volumes. So to summarize, the distance maps found no change in the tibiotalar distance maps from Pcfd to controls, indicating there was no arthritis. And when combined with the findings of Ock et al., they suggest that there's some different nonlinear mechanisms that might be at play here for the tibiofibular changes, with syndesmotic narrowing potentially providing an important diagnostic marker for anterior talar fibular ligament stability. So if it's our hypothesis, if it's intact here in early disease, it pulls the fibula into internal rotation and pulls that forward against the syndesmosis there, causing the decrease in distances. And then the additional stresses that are caused by this pulling it forward and impinging there, eventually, our thought is result in the later stage failure and widening. However, further studies are going to be needed to establish thresholds of these changes, and when we should be concerned about that further degeneration and injury that's going to lead to instability in the ankle arthritis. So in conclusion, they could be crucial in helping us develop the strategies to protect the joints from severe instability and arthritic development, and treatment approaches that reestablish the normal relationship between the tibia, talus, and fibula might help us be protecting that joint from the severe instability. And we hope that these more precise and objective data are going to be able to help us figure out when and where those things are happening to optimize correction. So toward that end, now I'll quickly sort of go through how our surgical outcomes were affected by correction of this peritalar subluxation associated with Pcfd. So in the study, we evaluated stage 1 Pcfd with a class D or peritalar subluxation type deformity. And so here, getting back to peritalar subluxation, you can see a couple of key features with the subfibular impingement blocking the calcaneus on the left and causing this widening or subluxation here in the posterior facet. And then the sinus tarsi impingement acting as sort of a hinge to open up and lever off this middle facet. So as discussed previously, this middle facet subluxation has been measured on coronal plane weight bearing CT imaging and found to be more pronounced in the middle facet when compared to the posterior facet. And this is just showing our measurements identifying that subluxation. The study also showed that middle facet subluxation was a strong predictor of whether or not the flexible flat foot was symptomatic or not. with 17.9% uncoverage, indicating a pretty strong likelihood that it was going to be symptomatic. So then we wanted to use our distance and coverage maps to study whether or not these patients were symptomatic or not, and how their outcomes would change if we corrected their subluxation, as we hadn't studied the patient-reported outcomes in our first study. As a reminder, we did find evidence of that substantial middle facet subluxation and sinus tarsi impingement in that first study. So our question then becomes, what happens when we correct this peritalar subluxation? Is it like we assume that the patients that are having the impingement in these regions are having pain as a result? And when if you correct that, you then correct the pain. So to give you an idea of what these corrections involved, here's the sort of schematic of what's happening with peritalar subluxation, with the collapse of that midfoot arch and the talar rotation and the hindfoot valgus that's happening. And to correct those, we medialize the calcaneus and plantar flex the first ray and lengthen the medial column to restore that arch and ideally correct the subluxation and impingement. So our objectives for the study were to assess the amount of correction of peritalar subluxation seen using traditional weight-bearing CT measurements and 3D distance and coverage maps for patients that were undergoing surgical treatment with hindfoot joint sparing procedures, and then to compare surgical Pcfd deformity correction with those improvements in patient-reported outcomes. And we hypothesized that significant peritalar subluxation correction would be observed following these joint-sparing realignments, particularly in the middle facet and the sinus tarsi, and that there'd be a significant correlation between the improvement in peritalar subluxation and improvement in patient-reported outcomes. So this was a single surgeon operating, and this is an ongoing study. Our inclusion criteria was symptomatic Pcfd that's failed conservative treatment and was undergoing a joint sparing procedure to reconstruct the hindfoot in adults. So all patients underwent weight-bearing CT preoperatively and postoperatively at 3 and 12 months and at 2 years. That with 2 fellowship-trained orthopedic foot and ankle surgeons performing our weight-bearing CT measurements that were by hand, including the forefoot arch angle, middle facet uncoverage and congruence, the talonavicular coverage angle, first metatarsal angle, and the foot and ankle offset. So patient-reported outcomes were recorded at all follow-up time points, with the last follow-up utilized for our comparative assessment. And we focused on the pain catastrophizing scale and the European Foot and Ankle Society score. And the other thing that we looked at was the magnitude of the correction and the procedures. So we performed our automated segmentation using D0 bone logic to extract the boundaries of the talus, calcaneus, and fibula from the weight-bearing CT. And the resulting surfaces were exported as triangulated surface models to Geomagic Design X with the subchondral and peritalar area selected. So again, we used our 3D distance mapping to look at where that impingement and subluxation was occurring, and included 18 patients with a mean BMI of 33.8, age of 48, and follow-up of 13.2 months. So it's pretty well balanced between right and left feet and biased towards females. So every patient got a medial displacement calcaneal osteotomy, which was that hindfoot lateralization. And the lateralization of the hindfoot was corrected with this medialization in the medial displacement calcaneal osteotomy with a mean correction of 9.6 millimeters. And then here you can see that lateral column lengthening that I was talking about, with about half of patients receiving that. And then every patient receiving a first ray procedure that was a combined lapidus and cotton in 59% of the cases, with cotton osteotomy, plantar flexing that first ray 6.7 millimeters. And here this is just showing what happened for the lapidus and cotton, where they fuse the first ray and insert that wedge into the medial cuneiform. So we saw a significant improvement in the forefoot arch angle, the middle facet subluxation as measured in the coronal plane by hand, middle facet incongruence, talonavicular coverage angle, talus first metatarsal angle, foot and ankle offset, which is an overall measure of the 3D deformity of the foot between the first and fifth metatarsal, the weight-bearing point of the calcaneus and the talus, looking at how well the foot's aligned. So the overall foot alignment was also restored. And we saw significant improvement in the pain catastrophizing scale for all these patients that were operated as well, and non-significant improvement in the European Foot and Ankle Society score. So looking at the change in distance mapping from the pre-op to the post-op, we saw that there were significant increases in distances in the sinus tarsi here, and a little bit of a decrease that was significant in the anterior facet. And if you kind of think back to that first study, the anterior facet was one of the things that was significantly widened, so it makes some sense to us there. But more importantly here, looking at the coverage maps, we saw that there was significant increases in coverage in all three joints, with the anterior, middle, and posterior facet all having significant increases, but a huge increase of 77% in the anterior facet. And then you'll notice also that we got rid of a lot of that impingement that we were seeing, with a huge decrease in coverage under 5 millimeters of bone contact in that sinus tarsi region. So here's just sort of an example of what general pre-op and post-op would look like for these patients. So you can see the restored arch with all of the hind foot medialization and the lapidus procedure and everything that happened. So looking at the coverage changes on a case, you can see that we significantly restored the coverage of these joints and decreased that sinus tarsi coverage. And here's that case shown with the quantification of the changes, where we're not seeing, as much coverage or impingement in that sinus tarsi region, and the complete restoration of the anterior and middle facets. So this is what we're kind of excited to start looking at, is how these changes impact our patient-reported outcomes. So we saw here that there was, in a combined model, and including our posterior facet coverage, sinus tarsi coverage, anterior facet coverage, middle facet coverage, and middle facet subluxation, they were all significant contributors to a model that had pretty good prediction of the pain catastrophizing scale. And even more impressively, even though not all patients saw a improvement in a significant improvement on average in the European Foot and Ankle score patient-reported outcomes, these patients that were able to have restored coverage and reduced subluxation had significant improvements in the patient-reported outcomes. And so it shows us, that we're on the right track of these ideas of biomarkers to be looking at. And I see I'm starting to run a little bit over my 35 minutes here, so I'll wrap up the discussion here and say that it does improve the outcomes. And you look at the corrections that you're able to achieve, and it becomes pretty obvious that these corrections can correct a whole bunch in the midfoot, the hind foot, and everything when you put it all together. And so our sort of next steps here are to figure out what's the individual contribution of each surgical correction to these deformities, and see how we can optimize those corrections to get us towards optimal surgery and getting all of those patients restored to having better outcomes. So in conclusion, they did have significant improvements, and the anterior, middle, posterior facet, and decreased sinus tarsi coverage were all significant and all led to the improvements in the patient-reported outcomes. And this is the first time that we've been able to show improvement in PROs being explained by these 3D changes in coverage. So with that, I'd like to thank you guys for your time, and give a special thank you to our huge and great team that we have working here with us at Iowa. And I'll open it up to any questions and discussion that you might have.
Thanks, Kevin. At this time, I kindly ask the audience members that if you're comfortable to please turn on your Zoom camera to allow for a better discussion. To ask your question, you can use the raise hand function under reactions. And if you're unable to do that, please type your question in the chat box and I will read it aloud. Walter, go ahead.
Great. Thanks a lot, Kevin, for the presentation. I'm going to start with a somewhat unusual question that doesn't relate directly to all the fabulous engineering work that you have done. But one of the things that I seem to notice is that the BMI of the patients that you had seemed to be very high. So is this particularly a problem for obese people, or was that just an artifact of the study?
So yeah, I'm glad you brought that up, because we're thinking along this line as well. And what we really think but haven't identified yet is that there are sort of two subtypes of this Pcfd, and one is more of a genetic flat foot that people tend to do well with, and tend to be low BMI active people that have no pain and no problems. And then we have the Iowa subtype, where we don't have as many mountains close to us as you guys do, so people aren't quite as active down here, and we get these high BMI people that are predominantly middle-aged women that I think after having a significant amount of overloading on all of their ligaments and things, and maybe some predisposition genetically with the formation of their foot, see this progressive collapse towards a lot of pain. And so they're all lumped together right now, but we need to sort of figure out how to separate.
But definitely kind of having too much weight for a long period of time seems to be a contributing factor to that. Interesting.
Yeah, definitely.
Yeah, thank you.
Michael, go ahead.
Thanks, Kevin. That was really interesting. Two questions. First one, what's the conservative treatment of this condition?
So conservative management typically involves something like an air cast, which is, kind of like a little arch support foot thing that you can pump up and inflate, and it'll move the arch up and, try to restore the shape of the foot. And actually, we have an interesting study. It went in as an abstract last year. I'm not sure if we've gotten around to publishing yet, but looking at the changes that the air cast has on these patients as well. So that's definitely a question and an area of interest for us, is how to better conservatively manage these patients as well.
Okay, and do you see long-term changes in the foot shape with this air cast? Do they wear it all the time, just when they're kind of at home?
So I think it's typically when they're like out and about and moving around, and I will say it's pretty bulky and I think a little uncomfortable for a lot of patients. And so, the other thing is, I think for most generic flat feet, you ask for more arch support in the shoes, and every shoe these days seems to want to say, hey, we have, some arch support, or, no arch support, that sort of thing. And so I think that there's some cognizance of, trying to make sure that we're helping these people maintain their arch and stuff, but we haven't quite figured out what the most helpful things are, and if we can, prevent the collapse, maybe even if we get in the earliest possible time point to start being a little bit more aggressive with conservative treatment.
Interesting. My second question was about arthritis. Where does it develop in the joint? Is it in the sinus tarsi area where you see the narrowing, or kind of all over?
So I'm not 100% positive where all of the arthritic development is occurring, but I know from the cases that I've seen that have progressed in our data series that it does happen sort of at the periphery of the joints, and you do see a lot of sclerosis and stuff extra-articularly, especially in the sinus tarsi and subfibular regions. And then in the ankle with the instability, we see it a lot more posteriorly in the tibia.
Okay, thank you.
Benno, go ahead.
Thank you, Kevin. Now, you mentioned that some of them are treated and some of them are not treated. What is the decision-making process, and what is the percentage of those ones that are treated compared to those that are not treated?
So I don't have the exact numbers or anything on this, but I know that the current decision process primarily centers around the patient's pain and function, and doesn't necessarily have to do with, as much the radiographic features or 3D changes that are happening in the feet, even though some people could come in with a foot that's not bothering them too much, and then they come back, a year or 2 years later, and they've failed conservative management and are having an increased amount of pain, and we see, sort of complete progression to full collapse, and they're sort of walking on their tailor head as it's completely rotated, and all the ligaments have failed there medially. So does that help answer your question a little bit?
Yeah, maybe another additional question. Did you check what you produce in the adjacent joints, so in the knee and the hip joint? The reason that I'm asking is because I had knee surgery, knee replacement, Oxford knee. And in that process, the orthopedic surgeon made a decision to realign my leg.
About that?
And 4 years later, my hip that was before proven by an X-ray completely sound was completely without cartilage. So,
oh wow,
did you check that, what you achieve by adjusting?
Yeah, no, we haven't looked at that yet, but that is in our current thoughts toward the future here, is looking at the hip and the knee joint as we have the high rise here, to be able to start having an eye towards what's happening in 3D along the whole limb. So we're excited to be down that road.
Kevin, you clarify what the high rise is?
Oh, you guys have one.
Well, not everybody here is in that lab.
Yeah, it is the first weight-bearing CT that's able to get a scan of the hip, the knee, and the foot on these patients. So we'll be able to look at how the whole lower extremity is changing in 3D, and not just rely on X-rays or anything.
Thank you.
Walter, go ahead.
Yeah, I have a couple of other questions with nobody else's hands up. The first one was that, you mentioned patient-reported outcomes, and I heard you say pain. Are there also any functional testing that you do, or do you rely exclusively on pain?
So I believe the functional outcomes are all patient reported as to their activity level and stuff. And so we don't just focus on like the pain indices of those. We focus on their entire like functional reported outcome score. But we also look at pain as well. But we have not done in-house testing or anything to look at, like gait changes or, walking speed and anything like that you could, maybe objectively get to.
And the other thing I was wondering is, presumably, how long does it take you to take a CT the way you do?
So for each pass, it takes about 30 seconds. So if we're just getting the foot and ankle, it's about 30 seconds. And then if we're getting the hips and the knees, there's, about 45 seconds to a minute of transit time between them. So the whole process takes about 3 or 4 minutes. Okay,
well, that's faster than I thought. And so obviously you rely on a static, I guess, double weight bearing position to do that. And so do you think there might be advantages of doing this for different joint configurations rather than just essentially standing straight?
Yes, you're talking about like getting some stressed imaging or something like that?
Yeah, I just assume, that the mapping that you get, the distance mapping that you get would depend very strongly on the joint angle. And let's say if you did somebody in a more squatted position or in a beginning of stance phase, end of stance phase for a running or walking cycle, I could imagine that would look quite different. And I was wondering if anybody had done any work in that and whether or not you think that might be important, or if this static straight up standing is good enough for the purposes of your studies.
Yeah, so I know that there's a lot of excellent biplane fluoroscopy research that is looking at those specific questions. What's happening during gait to these patients, and the changes that are occurring across the gait cycle and the relative bone positions and motions. And it's definitely something really interesting. I wish we had a biplane fluoro. Don, can we get one of those at some point? This is clinically available, and I think a lot more realistic for daily clinical use to get a 30-second scan rather than to do a whole gait analysis on a patient to evaluate it. So we're staying as close to the clinic as we can, but still have an eye on all those sorts of questions too, because I think that there are a lot of interesting implications as to those dynamic motions. And something that we're working towards is figuring out how best to get a few stressed positions that are relevant to the patient's pain and function, that we can better understand the disease process with.
And one of the points you mentioned is that, one of the aims is to have early detection before there's really any pain and functional problems. And so let's say you're able to do that. So somebody's not really symptomatic yet, but you have a way of evaluating that they might be at risk of developing, arthritis in the ankle joint. What would you do with those people to prevent that? So you have it detected early, they are not symptomatic yet. What do you do?
Yeah, so that's the question is, can you aggressively, conservatively treat those patients with other types of things, or do you want to get into the patient that you know is going to collapse and do a joint sparing reconstruction to prevent that pain from progressing down the road? And there's it's difficult to tell a patient that's not having any pain, we're going to do surgery on you. So I'm not sure that that's the answer. But if you could detect a patient that is just in the early stages of developing the pain, and we see, that they're following a prescriptive pattern of that progression, then I think those are the patients that we want to identify and help before they end up with arthritis and we aren't able to do a joint sparing procedure on them anymore. And then, because what happens to a lot of these patients late term is that they do just TTCs, or full fusions of the hind foot and ankle. And also do a bunch of midfoot fusions, and so they end up just walking on a block rather than having the motion, which these surgeries that we were discussing here are trying to preserve.
And last quick question: the images that you showed us, the comparison pre-post surgery, pre-post intervention. How far apart are they? How long after surgery did you do those? Immediately afterwards, or do you wait a year, or what's the time frame there?
I think our average was like 13.2 months post-op for those images. Yeah.
Okay. Great. Yeah. So is there any danger that you do this surgically and after 5 or 10 years you're back at the flat foot in the same configuration, or are these surgeries, have they been shown to be fairly successful also in the long term?
So that's a question that's unanswered in the literature at this point. We don't know necessarily how long these patients survive necessarily with all of these corrections and things. And, there's multiple different kinds of corrections that are all happening. And so it's also hard to say what the impact of each individual correction is and whether or not they were, yeah.
Thanks a lot.
Yeah, thank you. Great questions.
Don, go ahead.
Yeah, Kevin, thanks for the presentation. I'm glad you worked your way to an answer to Walter's question that I appreciated, which is something in between dual fluoro, video fluoroscopy, and weight-bearing CT. In the simplest sense, it seems like you could be looking at stiff versus flexible flat foot, because you could look at pretty simply the unloaded and the loaded foot and ankle. But I also think that a place here like Calgary, where they have both a weight-bearing CT right next to a place where they could do video fluoroscopy, it's awfully nice to think that you might be able to use the video fluoroscopy in a limited number of subjects to establish what is important, what few poses are important that you could collect in the weight-bearing CT, whether it be knee, ankle, or hip. And I think there's a lot of territory there. The one question I'd ask you is, I think you struggle with just so much data coming out of your analyses. And I wonder what your strategy long-term is. Are you going to rely on something like machine learning to take all of these data and turn them into something? Or are you going to try to identify a few key metrics? Because it just seems like there's so many measures here.
Yeah, that's a great question. And our analysis plan long-term is probably going to rely on picking the few key measures that we know are going to be associated with pain, that we think that we have something that can tie back to, like the sinus tarsi impingement makes a lot of sense to us. Subfibular impingement, you have bone on bone, and that's likely to cause a lot of pain and be a pain generator for these patients. But then I also think that there is a place for, when we have generated so much data, why stick to what we think is causing it, and see if we can start expanding beyond to do some unsupervised machine learning to see if we can predict which factors are influencing it, and then specifically to subtype these patients into those sort of idiopathic flat foot that are presenting at clinic, and maybe those patients that are that other subtype, which is the high BMI and stuff, and then let the data sort of lead us rather than trying to lead the data.
Glad you're a young man. You've got a whole career in front of you there. Thanks.
Tadawa, please go ahead.
Sure. Great presentation, Kevin. Really enjoyed it. Sorry, I joined on just a tad bit late, but you might have spoken about this already. So we've been playing around with the high rise as well in Dr. Mansky's lab, looking at some knee imaging. And so just in terms of the distance mapping, which you were using for your ankle measurements there, what's the potential use for that, for the same approach? Is there any way in which that the same approach could be applied to other load-bearing joints, such as the knee, for example?
Easily, yeah. But I think that the foot is a sort of unique structure in that you have a lot more shear that's going on in the foot with the load going vertical, and there being a lot more horizontal transfer. And so you're going to see, I think, a lot more utility for being interested in subluxation and where those joints are, moving away from each other and stuff in the foot than you would in the knee. But I think that it's also perhaps moving up to the hip, an interesting thing to consider subluxation and maybe some different measures of subluxation, like hip-centered rotation and stuff. And where I had the syndesmosis below this, and I also had our hip stuff that we're working on, but only so much time to go through all of this. But I'd love to sit down and chat with your guys' with Sarah's group here and see what you guys are doing and what you're thinking with the high rise sort of mesh brainstorm.
Yeah, no, for sure. I think that'll be a great idea. Thanks.
Reza, go ahead.
Thank you. It was a great presentation. Sorry, I didn't notice if the segmentation was automatic or manual.
So the first one that I showed, I was a little sly about it. The first one that I showed when we started was all semi-automatic segmentation using a watershed method, a hybrid watershed method that we had started in the lab a while ago. But then since D0 Bone Logic has come available, and we have a partnership to have them do segmentations with us for us. And I'm not sure if you're familiar with that software for the foot and ankle and hand and wrist, but with some quick selections, you just put a tag on each of the bones in the foot as to label it, and then in about 15 minutes or so, it spits out a full segmentation.
Awesome. Is that just particular for ankle and wrist, or not the other?
Yeah, so right now, all they've done is ankle and wrist, and Don's your guy that you want to talk to if you want to start thinking about knee automated segmentations.
Okay.
And then maybe the hip as well. So.
Okay. The question that I have here is that if the accuracy of the segmentation was a concern in your project.
So the accuracy of the segmentation is definitely a concern whenever you're looking at joint interactions, because you're talking about sub-millimeter changes. And so the segmentations that we took out of D0 Bone Logic, we actually popped into Slicer and verified, and it does a remarkably consistent job. Actually, we did not have to make too many changes. The big thing is if you have like osteophytes or something, it preferentially does not segment osteophytes. So if you wanted to include those in your analysis, you have to go and add those in.
Okay, thank you. Great job.
I have a question, Kevin. Do you have a ballpark for a surgical intervention that changes the position and orientation of the foot structures? How does that compare to non-surgical interventions like foot muscle strengthening or other sorts of therapy that may change that foot collapse?
Well, I would say that the joint sparing surgical correction isn't quite the nuclear option. It's aggressive for sure in comparison, and is going to do a lot more movement of the bones and things, I think, than any foot strengthening. And I think that a challenge is there might be some patients that still have intact structures that are, starting to fail, that maybe you could help out with more conservative management and stuff. But once the structures have failed, I'm not sure how much benefit you're going to get out of complete conservative management relative to the surgical intervention.
Mhm.
Thanks.
Any other questions from the audience? Okay, great. With that, please join me in thanking Kevin again for his presentation today, and thank you to all the audience members for their questions. I hope to see everyone again next week, and we'll be hearing from Andy Pohl. So I hope everyone has a great day and see you again next week.